Oh, what did he say? Oh, that is a great topic. He's real. I wouldn't want to make him mad. I know, I'm going to really try to simmer talk so much. Like I like the whole time I worked through like your Christmas break there, I was like, I hate this room so much because I have to wait for everything to like move, and like I could have already been halfway done through the exam by that time. Yeah, the middle room there is. So I do a lot of things portably, like on purpose, like pretty much everything with the exception of like skull, spine, or if they have like a whole bunch of multiple stuff that requires them, like they have a spine included in it, and then I just take them back to the room. But otherwise, I'll shoot like a lot of things portably just because I'm faster at it. So. I'm just giving them a few minutes because I said like 9:40, so in case anybody wants to still join.
I know I should have said that. I don't like it. You know what I think about I hate the colors. Yeah. Good job, man. Yeah, so like should be right here.
Catherine, can you be my model so I can go back over the foot and stuff? No? Can you leave your socks on? Sure. No. Oh, you have hairy legs? It's just you were here last week, so I want to go back over the foot and the toe with them real quick. And you already saw that, so do you mind? Okay. I don't care. Just take off one of your shoes. Oh, that's fine. All right, so. Oh, whatever. That's fine. Just take your sock off then for the toe at least. All right. All right. So people at home are going to go ahead and get started. We're going to record this again, so I'll post it later in case somebody jumps in a little bit after. I'm going to review the toe and the foot and then go into the ankle and the tib fib. So. Can somebody hold this for me? Can one of you guys hold the laptop for me? Actually, just take it off the phone. All right.
We'll message her. Be like, wow.
We need to see the light.
Did you guys not see it last week at home? No.
Is that because you can't see the ceiling?
Yeah, you can't see the light or anything.
Yeah, that's better.
The video,
I mean, Braylon posted a good video. I had video too, but I just posted.
yeah, and that one she posted on Facebook.
All right, so for AP toe, we're gonna go back over this. Anybody not listening? So you're gonna have your 10-degree angle going towards the heel of your foot. That's the best way I can describe it. CR joint, right at the toe joint, and then make sure you get about 1/3 all the way up through the metatarsals. So that's your AP. Your oblique, you always take your angle off. I always recenter. And then you're going to rotate the patient's leg a little bit oblique. So about 45 degrees for the toe. So our big toe is probably the biggest or the best one to use as far as like examples go. You will always get like a little bit of extra toe in there, so don't worry about that. So that's your oblique. And then for your lateral on this one, you're going to go all the way in so that this is flat. Still, the CR remains the same. If we had a popsicle stick, it would be perfect. You'd pull all those extra toes back so that only this one's pointing forward. Usually the patient can reach around and push it forward. So you can either put it here or like right here to get the rest of the toes out of the way. But the goal is to get this toe by itself. Right?
So the popsicle stick's gonna be pulling.
So yeah, you can either have it like that to pull these toes back, or you can have it forward and push that forward. And then you just match your CR to it. So remember this moves. So
That's for lateral toe.
that's for lateral toe.
What if it's a different toe?
If it's a different toe, so if you had your big toe or your second toe, you would always go this way, turn the foot in. If you had the last two toes, you come all the way out here. Sorry,
No,
Catherine.
you're fine.
Do the same thing. You could pull these toes forward, or you can pull them this way. It's really hard to go that way because you're going to get the sesamoid bones. So always pull them forward. Yeah. So popsicle stick is pretty much your friend at this point. Tape is really hard to get those toes completely out of the way, but if that's all you have, you use whatever you have. And then the middle toe, it doesn't really matter. You likely will never see middle toe ordered. Most doctors won't do that to you, but they'll order the big toe a lot or the pinky toe. It's right here at the joint.
Okay.
Yeah, so everything got moved. So it would be like right there if it was flipped the other way.
And the CR is gonna stay the same.
Yeah, it never moves. All right, so that's your toe series for AP foot. So put your foot flat again. It doesn't really matter where the patient's foot is at on the cassette too, by the way. Just make sure your CRs are correct. So right where your tarsals and your ankle or your metatarsals meet is where your CR is on this one, as well as up the third metatarsal. So right in the center, collimation for this could be like probably about there, but that's acceptable, as well as top to bottom. You always want to make sure you have enough room for your marker. You have a 10-degree angle again, just for your AP toe and your AP foot. That's it, okay? Make sure you're always at 40 inches SID on tabletop too. So you get your angle off, recenter, and then you'll do the same series. So medial oblique, rotate just enough. You don't want to clip anything off up there, so just watch your light. Everything's still the same. Third, CR doesn't change. And then your lateral, you'll rotate all the way out. So this is going to be a lazy lateral. You don't want to do that. So you want to prop their ankle up so that all of these metatarsals line up on top of each other, just like your metacarpals in your hand did. So you want to make sure they're nice and flat and that everything else is straight. All right. If the patient relaxes their ankle when you walk away, all of these tarsal bones are going to form like a curve, and you're going to see the fourth and fifth ones poking out when you take your film. So you don't necessarily have to repeat it at that point, depending on how oblique it gets. But your best bet is always to try to prop their foot up if they can hold their ankle up, or put a piece of like rolled up sheet or something underneath it to prop it up. A lot of older people will be able to do that. All right, so that's your whole foot series. So go ahead and stretch your leg all the way out for me. So for your ankle series, so your CR, it's going to be right at the Marquise joint. If you can see it.
I don't want to mess her up. Sorry.
Okay, perfect. So you have it right at the Mortise joint, and your foot's flexed. So you want this whole joint to be open when we take the picture. This is all the collimation you need. Not even really a whole third up the tib fib, depending on how long a person's leg is. But this is perfectly acceptable. You can go just a teeny bit higher, so you can open up your collimation more as well. Okay, so relax your foot. I always take the patient's bottom of their heel to rotate into a 45. You don't have to do that, but you just have them relax their foot and turn their leg at a 45-degree angle. So again, we're opening up this whole joint, and then you're going to see all of these tarsal bones as well as part of the metatarsals in the picture, and then your CR doesn't change. Still right at the joint space. So you want to make sure you include all of that in your x-ray, as well as the bottom, to make sure you have that whole joint in there. So that's your, yeah, so your heel is still considered a tarsal bone. Your calcaneus is a tarsal bone. So all of that has to be in there. So you want all of that all the way up to here. Okay. And then for the lateral, so bend your knee a little bit. She's going to come out to a true lateral. I always try to flex them if I can, again, to make sure everything is fully like lateral and stacked on top of each other. So you want your whole calcaneus, a little bit distal metatarsals, as well as everything in your ankle joint. So this will open up all these joint spaces right here. And then you're going to have the third of the distal tib fib. So that's your lateral ankle. Relax your leg. So go back up to straight. So for anywhere there's light that you're not going to be, go back to your lateral. No, I think some clinical facilities want you guys to put them in certain places. As a tech, you can do whatever you want. Just mark the film. So up here is fine, back here, down here, as long as it's not going to be in the super, or like the soft tissue of the anatomy. You don't have to train your brain to always go lateral on the outside of the patient's body part. So that's just a tech preference. So no radiologist is going to care. Half the time they're just looking. So weird. Okay. Yeah, it feels like it's like propped up on something. It's strange. All right, so find her knee joint. Sorry if that tickles, but her knee, like the top of her knee is right here. So her joint of her tib fib is going to be like right here. And then make sure you always have the ankle joint. I always do adults with my cassette turned, just so that you have more room. So she is barely long enough, or short enough, I should say, to fit in the light on the correct SID. The trick you'll learn in the future is that you can raise your SID up or drop your table down to get the whole tib fib. You might have seen techs do that. Train your brain 40 inches and be on the test, but ultimately, whatever you can do to get the picture, if you only want to shoot one film. If you have super, super long legs, it'll never happen, but like shorter stature, it should work. So you have ankle joint to knee joint, and then everything is AP. You can flex your foot. You really don't have to worry about that right here. The only time I ever do this is if they order an ankle series 2, then I have it flexed, and I just crop the whole ankle off and make it its own film so I don't have to repeat it. So yeah, so you find what works, then that way you don't have to take the x-ray all over again. So you have AP, and then if you go into a lateral, so roll onto your side. So this one, you're gonna want to roll onto their side, bring your leg over top. And the reason you bring their leg over top is so that everything is pretty much stacked. Sorry, bend your knee a little bit. You guys are gonna get all up in each other's business when you guys do this practical, by the way. So come prepared. Yeah. All right, so you always have to be careful. You want to clip off your knee joint or anything like that. Make sure you have all the way down to your ankle. If you feel like you're gonna clip the anatomy in any way, shape, or form, just do 2 automatically, okay? Don't waste your time trying to figure out everything on 1 film. It's perfectly acceptable to go ahead and just do 2 films, okay? Go down a little bit, they may not be able to see that. So, all right. So this is your lateral, joint to joint. Everything is going to be in a true lateral at this point. If she rolls a little bit more forward or a little bit more backward, it's going to throw these condyles off. You want these to be superimposed on top of each other. All right. So that's everything. Oh, so if we had to do 2 films, like say this is Ethan for a second, because he's got really long legs. I would actually put them more or less in like the middle of the film at this point, because we're not worried about getting everything on one. So you do like the lower half, and then you'd go back and do your upper half. Sorry. I always do these cross table too now, since most of the time they're ordered in the ER. It's just way easier. The more you become friends with your portable, the better your life will be. But if you don't work in a facility that has a portable, like an outpatient facility, then this is what you would do. So you do your upper and your lower. It doesn't matter which order you do them in. So same thing with you do for the AP. Okay. Any other questions? Good. Okay. Yeah, so we did on that one. No. So if you like, so
make sure you're hitting at least here, right?
yeah. So you really don't even need that. Like your whole leg could be cutting off right here, because all of this is going to get burned out anyway. So really all you're going to see is pretty much up to like about here.
Okay.
Like whenever the image is actually taken.
So try to get like to the toe.
Yeah. So if you're centered in the right spot and you collimate appropriately for the distal end of the tib fib, and whatever you get down here is not a big deal. So we're not looking at that in the AP ankle.
And that's the Mortise.
Yeah, this joint where the talus meets the bottom of the tib.
Okay, so that there, and then as long as you get past that, you get a little portion.
Yeah, they say a third, but ultimately like a third.
I think that'd be so much though, yeah.
And some people you do get a third on. It just, it really just depends on the patient's body anatomy. So. Yeah, like this.
I don't want to do lateral.
All the way. So medial, lateral. All right, anybody at home have any questions? Hopefully you guys were able to see that pretty well. I'm going to post it later on YouTube. If there was bad videography, I'm going to blame it on Jasmine, who's holding the laptop for me. I said if it's a bad video, it's your fault because you're holding it. I have a little All right, it doesn't look like you guys have questions, so I'm going to close this out. I'll post it later. Email me if you guys have any questions.